Hello, welcome back to another episode of Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare. We are an affiliate of the Kentucky chapter of Physicians for a National Health Plan. I'm Mark McKinley. I'm a volunteer with the group, and joining us today in the studio at the Habron Building is Dr. Eugene Shively and Dr. Michael Flynn. And we have Kay Tillow, Chair of Kentuckians for Single Payer Healthcare, joining us by Zoom. Hello, everybody.
Good morning.
Good morning.
Let me just say that the views and opinions expressed here on Single Payer Radio are those of the speakers and not the station. And just one other thing, you're listening to Single Payer Radio here on WFMP LP 106.5 Forward Radio. And this is an all-volunteer radio, community radio station. If you're able, we ask that you go to forwardradio.org. There's a donate button, and if you could send a few dollars our way, we'd really appreciate it. And if you have ideas for your own programming, then there at forwardradio.org, there's a button that says participate. We'd love to have you become part of the Forward Radio community. Kay, before we begin, can you talk a little bit about how folks could get involved with Kentuckians for Single Payer Healthcare?
I would love to, because what we need more than anything is for everyone to begin understanding the solution to healthcare and to help to push so that our nation will pass legislation that will bring about true healthcare reform covering everyone. So if you'd like to get involved, we encourage you to go to kyhealthcare.org. That's our website where we have information and links to our radio shows and other things. And you could also email me. That's nursenpo@aol.com. And I'd be glad to hear from you. And we need you.
Okay, good deal. Thanks, Kay. And Dr. Flynn, you want to start us off with any of your introductions?
Well, I guess let me begin with the disclaimer that we've used all along. As an emeritus professor in the Department of Surgery, I just want to make it clear that the views here expressed are my personal views and do not represent the views of either the Department of Surgery or the University of Louisville.
Dr. Shively?
My views do not represent the Department of Surgery at the University of Louisville, nor do they represent Taylor Regional Hospital in Campbellsville, Kentucky.
So I thought we'd begin with maybe set the table a little bit by talking about access to health care. I've got some numbers that are a little old, and I tried to update them a little bit yesterday, but 2017, there were about 28 million people in this country who were uninsured. And in 2018, there were about 44 million people, who are underinsured, who are defined as individuals whose out-of-pocket costs and deductibles are represented somewhere between 5 to 10% of their income. So this represents a lot of people, 70 million people, who are, for one reason or another, may be unable to pay their bills and are vulnerable to medical bankruptcy, which is a major issue in this country and is not an issue in so many other first world countries who provide health care to their citizens without making them vulnerable to medical bankruptcy. Now, yesterday, I got on to a series of websites to try to find out what the numbers were today as a result of the the pandemic, the job losses, and as Gene has said on a number of occasions, the numbers you get may vary a lot depending upon whatever site you go to. And what I was looking at yesterday was the Columbia Health Policy Management Division, Columbia University in New York, and indicating that instead of 70, now there are 80 million people who represent the uninsured and underinsured. And then, the breakdown is a little different than the one that I just gave, but there are more people and a lot more people. 80 million people is a lot of people who are vulnerable to medical bankruptcy. And in 2017, in France, which is a country of about 70 million people, there were zero bankruptcies, medical-related bankruptcies. In this country, depending upon the year, it could be anywhere from 200 to 800,000.
And those are bankruptcies and not the number of folks who have to carry medical debt to stay ahead of.
No, that's exactly. These are people who are filing for bankruptcy that is based upon the issues related to their medical debt.
So one of the other issues we need to talk about is surprise billing. Some people think they have really good insurance and they have an emergency, or go to the emergency room and their hospital is covered, or maybe their physician is covered, but the ER doctor is not covered, or the anesthesiologist is not covered under their particular plan, or the radiologist, or some other consults from physicians that they don't even know about. So they end up with a separate bill, and we call that surprise billing. And they're filing the full cost of this, and it's a surprise to the patient. Another interesting thing that's happened is that we've got insurance with high deductible. And one of the original reasons was that we would have this high deductible, so we would try to force patients into being a little more careful in how they spent their insurance money. And the idea was that if you would search out your physician or your hospital and get a cheaper rate. Well, we now got data to show that that doesn't really work. That it's possible to do that, but it's very, very complicated. And, if you're sick and you find a doctor you like, most people are not going to go into great detail and trying to figure out what one thing costs and what something else costs. Another gimmick that's going on is transparency, and hospitals have to list what they charge for certain things. Well, the problem with that is that some hospitals charge different insurance companies different things. Each hospital has got a different contract with different insurance companies. And some hospitals have a different rate for the same insurance companies, depending on what type of policy they have or who their employer is. So it becomes extremely complicated and very difficult to figure out.
Go ahead, Mark.
Well, I was going to ask Kay, Kay, do you have any insight into any of these discussions about surprise billing or the high deductible plans or shopping around for the best price when you're having a heart attack? Kay, I think you're muted.
Sorry about that. I did
okay.
that so I wasn't making any noise. I think that, all of those things like the high deductibles, they're put there by the insurance industry because their theory about what's wrong with our system is that people are overusing the healthcare system. They are wrong in that, but they like that because that allows them to make more money. So if they can put barriers up that will keep people from being able to get health care, then they don't have to pay for it and they can increase their profits. And that's the problem. I mean, the insurance company says that is there to keep people from overusing. The reality is that the deductibles function to make people underuse. In fact, underuse is a much bigger problem in our society than overuse. We have a lot more people who need care and who could be helped if they could get to the care than we have people overusing it. So it's a wrong concept and it needs to be removed. And of course, that's why in the single payer proposal, there would be no deductibles, no co-pays, so as to remove the barriers to care and make sure people can get in early for preventive care and actually get the care they need. You know, going to a doctor is not an expensive overall thing to do. I mean, people need to go and not to hesitate to get in, and the co-pays and deductibles really discourage that.
Dr. Flynn?
Yeah, this actually goes almost back to the very first discussion we had here about the fundamental issue of healthcare in this country, which is considered a commodity vulnerable to exploitation by for-profit entities as opposed to an essential public service. Now, what I'd like to do is tell a story that's going to sound a little off the wall, but it'll hopefully get us back to a little bit in front of Gene's issues about some of those specifics about surprise billing, because there's a reason why these all exist. So hang in there with me, because this starts off looking a little strange. So when I was younger, I had some wild hairs growing out of my head, and one of those led me as a resident at the University of Maryland in the January and February of 1968. I ended up in a Vietnamese civilian hospital treating the casualties of the war. And my first encounter, surgical encounter, was a patient with a shrapnel wound to the abdomen. And when a hand grenade or a mortar or a landmine explodes, the casing around the explosives fragments into a bunch of small pieces which fly around and cause a lot of damage to the body. So as Gene knows, I made a long midline incision. I put my hand down in the abdomen and feeling around and had one of these holy you-know-what moments, because I could feel something moving around in there. And as I explored a bit more, my hand came out with a 6-inch ascaris, a tapeworm, wrapped around my finger. And throughout the time I was there in Vietnam, I realized that most of the rural population, the folks living in the hamlets and in the boonies, were undernourished because of this tapeworm infestation. So starting in the mid-1970s until the mid-2010s, there has been an explosion, a 3,000% increase in the administrators, managers, bean counters, and bureaucrats in healthcare in America compared to practicing physicians. So there are 10 of them for every one of us. And the highest, the peak, the increase occurred in the mid-90s with the explosion of all of these for-profit health insurance companies. So the question is, and there are other systems where this doesn't exist. All the branches of the armed forces have healthcare systems. They have hospitals, they have clinics, they have a lot of different specialty things. They take care of the active duty, they take care of the retired, and they take care of dependents. And in the Navy, they have things like flight surgeons and submarine medicine. That really, there's not a lot of market for submarine medicine out of Baptist East. if you are a a physician in the Navy or the Army or the Air Corps, you're a medical corps officer. If you are an administrator within that medical system, you are a medical service corps officer. There are many more medical corps officers in all branches of the military medical system than there are medical service corps officers. So the existence of all of these bean counters and bureaucrats in our civilian system is essentially the result of the for-profit process. Another example is the National Health Service in Britain, which has many more practicing physicians than they have administrators. So the question is, what do these people do? And Gene, the question to you is, we're this topic of where does the money go? How much revenue money is sloshing around in healthcare in this country on an annual basis? And then the follow-up question to that is, how much of that money is not used to provide healthcare? We can then get into some of the more specifics about why these bean counters and bureaucrats exist, because I think that's the key to that issue.
Well, I have a similar experience with an Ascaris worm. I was in.
Everybody's got a tapeworm story.
I was in Cambodia on a medical missions trip, and I was operating, and the NG tube wouldn't work. And I asked anesthesia to irrigate it, and it still didn't work. They pulled it out. There's a great big Ascaris worm on the end of it. So that's a common thing in the third world. The United States spends about 3 times as much on administrative charges than the rest of the world is. And some people estimate that if we just could get the administrative cost of American medicine down to what it is in the rest of the world, and if we could reduce the pharmaceutical cost, we pay twice as much money for pharmaceuticals as any other country in the world, and we're responsible for half of the money spent on pharmaceuticals in the entire world. If we could just affect those 2 factors, we could probably get our healthcare costs down to a reasonable amount.
But Gene, to get back to the question, though, if you have, it seems to me there's about $3 trillion or something like that sloshing around in healthcare.
Yes, it's around $3.5 trillion, which is the 5th largest economy of the world. It's equal to the GNP of Germany. And it's a phenomenal amount of money.
So how much of this money is siphoned off for other non-health care issues?
Approximately a third of it. Approximately $1.4 trillion. Now, I spent a lot of time last year trying to figure that out. Now, as you know, the numbers are constantly moving, and it's hard to get good data on this. So this is an approximate number. But approximately a third of the amount of money we spend on healthcare does not go to patient benefits. It goes to things like administrative fees. It goes to stockholders, not only for insurance companies, but for hospitals. And all this money does not include other things like long-term care, nursing homes, emergency medical services. I haven't even looked at those numbers. So at least a third of the money we spend on healthcare in this country is wasted and doesn't go to patient care. One needs to ask the question, why, if you're sick and you're in the hospital, why is the money that you spend to pay for that, why should it go to a stockholder? We're the only country in the world who does that. We're the only country in the world who advertises. It goes on and on and on.
Now, I think it's reasonable that between the mid-1970s and the 2010s, that the complexity of healthcare probably makes it reasonable that there need to be a few more administrators around to deal with the complexity. But to have a 3,000% increase so that they've got 10 of them to every practicing physician, the question is, what are they doing? And the way the money goes, some of it goes to administrative costs, which is probably a relatively small amount of the that's called administrative costs, but it's a relatively small amount. And as you mentioned, there's advertising and marketing. I've got a thing here that suggests that $30 billion a year is spent on marketing. And this is the direct to consumer marketing, so that the drug companies or the hospital management systems wanting to attract somebody to come to that system instead of another system, both providing care, one having robotic surgery and the other not having robotic surgery, huge amounts of money. Political contributions. This system would not exist without political contributions. The senior senator from Kentucky gets a lot of money from the healthcare industry. He's turned political contributions into an art form. And as you said, then there's the issue of investments. If the insurance company has money that they invest, and then the return on that investment, where does it go? Does it go into paying for health care, or does it go into a CEO's pocket? Executive compensation. The CEOs of the for-profit insurance companies are making somewhere between $20, $30, $50 million a year. This is not a golden parachute retirement plan. This is a one-year salary. And then, as you mentioned, Gene, the investor dividends. So all of these bean counters and bureaucrats are busy doing all of those things to keep that $1.4 trillion from being used to pay for health care, but they're either putting it in their pockets or using it to maintain a system that allows them to do these things.
Well, it's not only the for-profit insurance companies and hospitals that are bringing in a lot of money. A lot of not-for-profit hospitals have huge administrative costs, and there are some hospital administrators in the non-for-profit business who are making millions of dollars. I mean, between $20 and $30 million a year. Why should a not-for-profit hospital, a CEO, make that much money? I think the answer to your question, Mike, is it's greed. And beginning in the 70s and then through the 80s and 90s, we changed our healthcare system from a non-for-profit service industry to an industry. And two of the sentinel events happened here in Louisville. One was the first for-profit nursing home, which later became Humana, and then all the for-profits actually developed from that. And then the other thing that happened is that an attorney here in Louisville who was advertising on the park benches around the courthouse, was challenged by the Kentucky Bar Association. It went to the Supreme Court and it said it's okay to advertise. So those two things put for-profit, a commercial edge on medicine, which has gradually evolved into an industry.
Okay, guys, let me just say to our listeners that you're listening to Single Payer Radio here on WFMP LP 106.5. We are in conversation with retired surgeons and emeritus professors, Dr. Michael Flynn and Dr. Eugene Shively, and Kay Tillow, Chair of Kentuckians for Single Payer Healthcare. Let me just say, on the subject of tapeworms, well, this triggered a memory of an article I read a few years back, and Warren Buffett has said that the complexity of our system is the tapeworm of American competitiveness, and this is a subject for another show, but how it reduces businesses where they could spend their time taking care of their business, but they also have to, our system requires that they peel off time where they've got to deal with providing health care for their employees. Doctors, if you all could talk about, when we talk about administrative cost, back in the 70s, I mean, were staffs in your all's practices having to deal with insurance companies to get procedures approved, to negotiate fees? I mean, how did that develop?
It was much simpler. I started practice in the late 70s and the 80s, and you usually just submitted a bill and they sent you some money back. Even the for-profit insurance companies were doing that. And the hospital I was dealing with, the same thing, submitted a bill and they got reimbursed for it. Then we didn't have all these problems with getting pre-authorization, making multiple phone calls, multiple emails, finally talking to a doctor about this patient that they've never seen, and they're having the final decision. An example of that is a patient who has metastatic cancer. In the last few years, we've become, medicine in general and medical oncology has become very good at treating cancers. And so we need to know if they've got recurrence or not. And it's often really quite difficult a few months later to get another PET scan to find out if there's a recurrence, because there may be other drugs that we can use to treat that patient. But it's frequently a real hassle.
I joined the university in the mid-1980s. For about 6 or 7 years or so before that, I was in a small practice, part of the time by myself and part of the time with a colleague of mine, a friend of Gene's named Frank Miller. And I had three employees in the office. And they kept the medical records, they entered the patients, they did the scheduling. And, getting insurance payment or getting approval to do so just wasn't an issue. I agree with Gene, absolutely. And then as the insurance, the for-profits came in the 90s, that's when the world started to change. And I think I mentioned this on a previous program. I called, I did a grand rounds back in December of 2019. And before I did that, I called a colleague of mine, a fellow named Ted Young, who's a head and neck surgeon up in McMaster University in Hamilton, Ontario, and just to find out how things worked up there, because in the clinical aspect of a surgery department, we have a whole bunch of people who do pre-authorizations. They make all the phone calls that Gene's talking about. They have to deal with the insurance companies. We've got over 1,000 for-profit insurance companies. Each insurance company has 10, 15, 20, or 30 different plans. And the complexity of trying to navigate through all of this administrative hassle of different plans, what one plan covers, another plan doesn't cover, is just a nightmare. The Canadian system, the money comes from the central government. It goes to the provinces. His office was kind of like my office back in the 80s before this all started. And they didn't have trouble getting a second CT scan if you needed one, or if the first one wasn't working properly, or it was a poor quality scan. And then someone in his office, he just had one person in the office doing the insurance business, and they sent the bill to one place. They sent it to the provincial government, and not 1,000 different insurance companies. And 2 or 3 weeks later, you got the money. And that's the way it was back in the 80s. So, to get back to the tapeworm infestation, the rural population in Vietnam in the 60s were malnourished because of this tapeworm infestation. Our healthcare in this country has a massive infestation of bean counters and bureaucrats whose goal is to figure out ways to take that $1.4 trillion that is not being used to provide health care and do something else with it, like keep it, pay somebody with it, use it for investments, and this is the fundamental issue of a commodity versus an essential public service.
I think it's very important to emphasize that most people who are proposing some type of change in our healthcare system, they usually talk about how they're going to change it. They rarely, particularly if they're a politician, don't talk about where we're going to get the money to do that. And it's my assumption that their plan is to get the money from increased taxing. But I think we need to emphasize that we've already got $1.3 trillion is sitting out there as being wasted. If we could change that, then we could dramatically do a system without really increasing taxes very much.
Go ahead, Mike or Mark.
Well, I was going to ask Kay, because Kay, haven't you said before, the money in our healthcare system, the money is already there?
That's true. We have sufficient money. It's actually something around 19% of the gross domestic product, and it's getting close to 4 trillion. It's 3-point-something trillion in the system. That's certainly more than enough to provide wonderful health care, excellent care for every single person in the country. We could expand the care to all of those who are insured, and we could bring improved care to all of those that are underinsured, and add in, the things that people aren't covered for, like mental health and eyeglasses and nursing home care. And, we could cover all medically necessary care with that money if we would take out the administrative waste that is basically caused by the for-profit insurance industry and their efforts to make money and to pay huge salaries and to increase the administrative costs. Why should we have insurance bureaucrats questioning what physicians and patients are able to do. I mean, just think about it. Who should make the decision as to what is the proper procedure? And yet that's what we have every day, is that the insurance company has a review person that intervenes. And, we learned about that back in the 90s when Dr. Linda Pino from Louisville testified about humanist practice. And Dr. Pino was one of those physicians who did the reviews. And she revealed that the company paid those doctors more if they would turn down more requests by physicians for procedures that were expensive. And it was revealing about what's going on here. I mean, why do we have this insurance industry intervening in the system when virtually they make no contribution to the care? And we have good physicians and good hospitals. We could take good care of our people if we could reclaim that money that they take.
It's not just the insurance companies. The entire practice of medicine in this country has become a corporatocracy. And let me give you some examples. There are colleagues of mine in medicine who over, I guess, the last 5 or 6 years have allowed their practices to be taken over by healthcare organizations that used to be hospitals. And so they came in, they installed computers, they take care of all the administrative hassle that I used to have to deal with when I was in practice. And I was having to sit down with the employees and negotiate paying them and try to figure out how to, because when I was gone or when Frank was gone, money didn't come in. So, but these people needed to get, and they should. I wasn't, but it was a real issue to have to deal with all that stuff. But what's happened, once the organization, the hospital management organization or the healthcare organization writes the paycheck, then they start making rules. And I know a number of internists, primary care physicians, who have either retired or left practices because of the influence of having to see X number of patients in X time frame. And if you've ever dealt with anything like that, you walk into the room, and whether it's a surgical patient or a psychiatric patient, you don't always know what you're going to get into. And I could tell 100 stories about going into something I thought was a very simple post-operative visit, and you find out that there's a whole lot of other issues that I spent half an hour in there when I thought I was going to spend 10 minutes. And so what happened is the bean counters are sitting behind desks with computers. I'll give you another example of this. When the Catholic Health Initiatives took over the Kentucky one, Jewish Hospital, Fraser Rehab, and St. Mary and Elizabeth. This was, 5 or 6 years ago. It was a good while ago. And I was on the institutional review board. I still am. There was a very nice lady who runs the pharmacy at University Hospital. Now, pharmacy at University Hospital hands out pills and drugs and IVs and all the usual pharmacy things. But in addition to that, they have an oversight responsibility for all of the research that's done using various cancer medications, monoclonal antibodies, whatever's going on in research that involves pharmaceuticals at the University of Louisville. And she was sitting in there one day actually crying because shortly after they came and they took over the management of University Hospital, along with those other things, which is a whole other story. Somebody shows up in her office and explains to her that she needs to get rid of X number of employees. She just their model. Somebody sitting in front of a computer in Denver, who is looking at University Hospital, which is a level 1 trauma center and has a lot of research going on, as essentially a community hospital model. And ended up having, I mean, it was crazy stuff. Another example was they do now, but there was a period of time when CHI took over. They got rid of all the social workers on the surgical floors. So this is a level 1 trauma center. So you get a gunshot wound or an automobile accident, or somebody gets helicoptered in from wherever. They get operated on. They spend some time in the ICU. They may have another operation. They go on to the wards, and then they need to move them out to rehab. Well, the job of the social workers was to move the people onto the rehab things, not the residents and the medical students and the fellows are not doing that. They're busy taking care of the stuff that's coming in the door. So it was crazy. And fortunately, University Hospital has got itself back in order, and it's doing fine. But this was just one of those. But the point here is that the system was being run by the managers, not by people who were taking care of the patients, not by the professionals, and this has happened in other areas of medicine where these clinical practices don't have the independence they had in the past because they get a check from the company.
Dr. Shively?
Another example of that is we've lost continuity of care. When I first went into practice, you ask a patient, who's your doctor? And they always name someone. And they went to that doctor when they were sick. And that doctor referred them to a consultant or specialist when they needed to. And that doctor knew what was going on with the patient. And now, when I just retired last year, the majority of patients I saw did not have a primary care physician. And we also increased the amount of very expensive care. For example, if you've called a hospital or a doctor's office, they've always got an answering machine, and it says that this is an emergency, call 911. Well, we used to never do that. The primary care physician took care of the patient. In the last 10 or 20 years, if I had a patient that came in my office, or my wife, who's a wound care specialist, had somebody that came in the wound care clinic with a very high blood sugar, like 600 or 700, we'd just call up the family doctor and they would take care of that. Now it's almost 100% send them to the ER. Well, if you send a patient to the ER, then you've dramatically increased the cost, because the ER doctor doesn't know the patient. He doesn't know what's going on. And as a result of that, to protect himself from malpractice, he's going to order a bunch of tests. And then the patient now, instead of getting admitted to their primary care physician, they get admitted to another doctor who they don't know. And then they see specialists that they don't know. And if they go to ICU, they see another doctor they don't know. And so it really creates a situation that increases cost, plus lack of continuity of care, and anxiety among the patient and the family, because we don't have somebody in control of the patient who can sit down and talk to them, who knows them personally and knows all their idiosyncrasies and who's been around and talked to them for years.
Dr. Flynn?
Yeah, and again, sounds like we're sitting around here, griping, but these are important examples of how a healthcare system has lost its way and has been literally taken over by the administrators. Another example is the electronic health records. Epic is an electronic health record system that involves putting information into computers. And from the standpoint of not having to try to interpret the bad handwriting of physicians, this is typed in. So that's a benefit. Having said that, the Epic system that is used in this country is, compared to other countries that use the same vehicle, is insanely complicated. And most of the complexity is due to billing issues. And I dealt with the Epic system before I retired, and you would literally sit in front of a computer and scroll through a screen after screen after screen of irrelevant material until you finally came down to the bottom line, which was a little small note that told you what you needed to know. You didn't have to go through every blood test that was known to man that was done 13 times during the course of the hospitalization. So, and another sort of spin-off or side effect of that, one of the interesting things that the surgery department did shortly before I retired was they kind of did a survey of surgical residents' quality of life. Now, Shane, with the way we were trained, they couldn't care less about our quality of life. But it was a good thing to do, and it was very interesting because the major complaint that the residents had was the difficulty and the amount of time and the complexity of having to deal with this Epic medical record system that had so much information in there that didn't have to do with patient care. One of my partners is a nice young woman who's doing the kind of surgery I did before I retired. When this started, told me that she had seen patients, and she after they were done about 5 or 6 o'clock in the afternoon, she was in the office until 2 o'clock in the morning, filling out this all of the checking all these boxes. And the end result of that was that they had to hire a scribe. And that's what has happened in so many other places. In order to get all the information in this system that is mostly about billing, not about patient care, in order to get paid, because that's the way this thing is set up, there's an additional cost of having to hire somebody who puts that information in.
The electronic medical record is the number one issue for early retirement of physicians. And the information in the electronic medical record is frequently incorrect. I've seen 2 studies just lately. One was done about pharmaceutical errors, and the electronic medical record is designed that if you're giving a drug and then they've got several other drugs, you're supposed to be able to detect if there's a conflict. They did a study and found out that 20% of the time it was incorrect. I saw another study recently where over 20% of the data in the electronic medical record was incorrect. And the reason is they're templates. And let's say a patient comes in to see me with a breast cancer. And you've got to fill out all this other stuff. And you get to a template about cardiovascular disease. It's set up where it says yes or no. Well, if you put yes, there's got to be at least 300 different types of heart disease. And I've seen multiple patients where it says no because it's easier to push that button. But in actuality, they had something, but, it takes so much time to put it in. My wife was the same way in a wound care clinic. She would finish seeing patients about 4 or 5 o'clock in the evening, but she never got home till about 9 or 10 at night because she was fooling with electronic medical records. Now, what I did is I figured out a way where I dictated, and then I had the nurses fill out the basic electronic medical records. I would dictate and then have that transcribed over onto the electronic medical record. If I tried to type all that in, I would have to see only a few patients a day.
Yeah, I did the same thing, and I had to pay the additional cost of the cost of the transcription and the typing and the rest, which I was happy to do, but that was exactly the way I dealt with it because it was insane to do the other things. Now, I know we're getting close to the end. Before we end, I would like to make a comment about the future, kind of as at the end of the day here. So I just want to let you know whenever you're about to pull the plug on us.
Now we got a profit.
Now don't call me a death panel here. Mike, why don't you go ahead because we're in the wrap up stage.
We don't have a system in this country. We have a patchwork of health issues. We have a governmental insurance, Medicare and Medicaid. We have a VA system, which actually there are a lot of issues about the VA, but the VA does a pretty good job taking care of the veterans. My wife is an operating room nurse, and she's actually working at the VA today. She's in ophthalmology, and they're doing 6 or 7 cataracts a day. They're catching up. The armed services, I've mentioned earlier, they've got their own healthcare systems. Got the public health service. And a huge amount of this of healthcare in this country is in the hands of these more than 1,000 for-profit health insurance companies. So, this is pretty bad, in my opinion, because it isn't a system. It's just all of these different entities, some working together, some working against each other. So the question is, can it get worse? And the answer is yes. The next question is why? Before the University of Louisville stepped up and accepted the public responsibility of taking over Kentucky 1, they were negotiating with some kind of hedge fund in New York called Blue Mountain. I don't remember exactly what it was. It was blue. Back in the in 2015 or 2016, one of the downtown hospitals management and their anesthesia departments got into some discussions, and in all fairness, I thought they both were not doing a very good job. The end result of that was a company, an investor-owned company, was hired to provide anesthesia. And the beginning of this was really a scary experience. What I worry about in the future is the prospect of investor-owned companies getting their hands into the healthcare cookie jar. Running nursing homes, they already do that. Start running hospital systems. The goal of hedge funds and Wall Street is to make as much money as possible. And if they get involved in healthcare, their goal is not to provide healthcare, but to suck as much money out of it as possible. And I think this is a scary prospect for the future unless there is a major change in the political ruling class in this country.
That's already happening. I've got a couple articles here where equity companies are buying into healthcare.
Yeah.
I'm sorry, guys. That's another episode, how private equity companies are becoming more and more involved. Dr. Shively, thanks for coming up from Campbellsville. Dr. Flynn, thanks for jogging over from the Cherokee Park area. Okay. We'll see you soon down in Old Louisville. And I'm sorry we don't have more time. It flies by. But guys, thanks so much for Single Payer Radio. This is Mark McKinley. Thanks very much.